Hi everyone, I'm going to be talking about the OB Falls Risk Assessment. We're changing our Falls Risk Assessment tool. You're going to see this happen with Cerner go live on February 23rd when we switch over to Cerner for our new charting system. We're changing our risk assessment tool for falls because the Joint Commission says we should use things that are appropriate for our population setting and services. We use Morse falls right now. It's very well researched, but it wasn't really designed or made or used with OB patients in mind. We still will use Morse falls for our gynae patients, but for all other adult patients, we're going to be using our new tool. A little bit about our tool. We combined two different tools, the Obstetric Falls Risk Assessment System, designing UCLA, and the Falls Risk Assessment for Perinatal Patients tool. Both of these tools were designed with inpatient OB population. And there's a really great article that you can access through A1 if you want to read more about OFRIS. They've had really great luck with it in reducing falls for inpatient OB patients. Pregnant people fall down and go to the ED for it. Whether or not that's something that we think about for pregnant patients, we probably do as nurses, but just to be aware that this is an important assessment for us. We don't want any falls that cause a lot of other issues. Here's some risk factors that we're wanting you to keep in your mind when you're assessing your patient. If they had a fall in their last trimester, that's something you're going to want to take a note of. Prolonged bed rest for those auntie patients that are on bed rest for any time in the last 2 months of your assessment. They just have less activity, so their muscles aren't as strong. If patients had hemorrhage, active laboring, this one sounds strange, but we all know that your center of gravity changes when you're pregnant, and that can contribute to falling, especially if you're trying to move around during labor a lot. The first time patients get up after delivery, we're assisting them. That's a time where they're having a higher risk for falls. If the patient has preeclampsia, anemia, fatigue, these things can change, your blood pressure, your feeling of dizziness, your strength. If the patient has uncorrected visual impairments, this is another risk factor. Medications, we all know these, but just to point them out, the magnesium sulfate, that can make patients feel groggy and awful. Any sedatives, any general anesthesia, and any hypertension medications, and we'll talk a little bit more about that in a bit. This is what it looks like. You can chart an ad hoc in the forms. You can chart an iView. I personally like to do just the forms. You don't have to chart in iView. The first one you ever do, there will be a task that pops up in Care Compass, and they'll talk about this in training, and you can chart from there, and it'll pull up the ad hoc form. If you want to chart an iView, that's after the first one, then that's totally fine. Okay, so the first question is this the first one, or are you reassessing the patient? Pretty obvious. This whole form's pretty straightforward. History. Any bed rest in the past 2 months? Any falls in the last 3 months of pregnancy? Any visual impairment? Diagnosis in lab, if they've had preeclampsia, if they've had a low hematocrit. Mobility, again, laboring, active laboring, if they're feeling dizzy or lightheaded, if they're needing help with ambulation, those are things that contribute to a higher risk. If they've had any blood loss in the last 24 hours, then you would select the appropriate one. Medications this encounter. This means you're not thinking about their entire medication history, just what medications they're being affected by at the time that you're assessing. So if they did take fentanyl in labor, but now they're like 48 hours postpartum, you wouldn't click narcotics. If they And same with anesthesia. If they did have an epidural later, but now they're a far postpartum patient, you wouldn't click that either. And for antihypertensive meds, if they get a new dose or a new increased dose, a new dose or a dose that's higher right now, then I would click it. So you click all these yellow sections, you'll see a score pop up in this small box down here. And then it'll tell you if the patient's low, medium, and high risk, and some suggestions of what interventions to do. You can see that the low risk is the standard fall prevention interventions. You can right-click the fall prevention procedure on the right side. It's the last box on the right. You can right-click it. There's a reference text. It takes you to the Lucy doc about the house-wide fall prevention policies, where it shows us all the ways that you can reduce your risk. So you can do the same thing in iView. The only difference right now is that it's just going to show you a number. It's not going to tell you low, medium, or high. So we are requesting that that's being changed. But if you don't know what that means, you can always open the ad hoc form and find this text. So again, low, medium, high. These are pretty much the same interventions we've always been doing. If the patient is a high-risk patient, you would put a yellow band on them. If the patient had that hemorrhage and is on MAG, if she just has a high score, we're supposed to put a yellow fall risk band so that we're following the house policy for falls. But a lot of these interventions that are listed here are things that we're already doing. We're just going to be applying them to different scores. So how often are we charting these? When you're admitted, you'll see on your care compass that they want you to chart the obese falls risk assessment. It'll take you to the ad hoc form. You can chart it every shift. You can use the form or you can use iView. Either way is fine. If the patient's condition changes, again, you can use the form or iView. Either is fine. Some examples: the patient hemorrhages, you would do a new falls risk assessment. She has a new diagnosis, falls risk assessment. She gets a change in meds, new meds. That's when you would do that again, falls risk assessment. If the patient says, I'm feeling kind of dizzy and lightheaded, that's another time that you would re-document that. And if the patient's fall risk changes, please just let that be known when you report off to the next nurse. All right, if you have any questions, you can email me or contact your managers or Joni.